When there is lack of nutrients, so the cell is starved, then it's a type of adaptation that the cell wants to survive. So there are low growth factors. Then there are some changes in cell that is called autophagy. So in autophagy, the cell eats its own components, eating itself. So you imagine this is the mitochondria, lysosomes, endosomes, some endoplasmic reticulum. So this should be eaten by the cell itself. A membranous structure first is formed that is believed to be originated from endoplasmic reticulum. This membrane is called phagophore. But for formation of this phagophore, a simple model is the 4-protein complex called initiation complex reacting with the protein complex called nucleation complex. So by reacting this initiation complex and nucleation complex, there is a nucleation and formation of this phagophore that these are mitochondria, endoplasmic reticulum, and other organelles that they should be eaten by this new membrane. Then we should know that there are some genes called ATGs, autophagia genes, that play a role in controlling autophagia. Autophagia is not a random situation. It is programmed. Autophagia is controlled by autophagia genes. Then this membrane should elongate. So after the nucleation, this first step is called nucleation, which makes the phagophore. Then it's elongation. This membrane elongates and closes by LC3. LC3 is a ubiquitin type of protein that we talked. It causes fragmentation in protosome, ubiquitin-like protein. It's called microtubule protein associated light chain 3, LC3. This works in elongation and closure of this phagophore. Here it is closed, and we have the organelles that should be deranged. So here it is closed, elongation and maturation. Here, this structure, and at this stage it is called autophagosome. When it is closed, it is called autophagosome. Then imagine this is lysosome, that it contains hydrolytic enzymes. This starts to fuse with this lysosome and makes the autophagolysosome. And here, this inner membrane is also disappeared and only one membrane is seen. And by action of these lysosomal enzymes, then all these are degenerated and we see debris. So autophagolysosome, action of hydrolytic enzymes in lysosome, degenerates all the components. So here is whatever occurs in autophagia. Autophagia can be seen physiologically as the cell degenerates. These degenerated parts should be deranged. So it can be seen in cell aging. Aging a physiologic process that autophagia can be seen. But also it can be seen in pathology states such as atrophy. Atrophy can also be seen due to autophagia. If due to decreased workload or whatever the tissue is atrophied, one type of reaction in atrophy is autophagia. Also, cancer. In cancer, autophagia can both cause and defend cancer development. So, in cancer. In infections such as herpes simplex virus type 1, in Shigella species infection, in these infections, for example, the cell uses autophagia as a defense against these microbes, so prevents these microbes, so it can be used as prevention in some infections. And also in some degenerative diseases, autophagia can be seen. So both pathologic examples and physiologic examples for autophagia. In neurodegenerative disorders, for example, Alzheimer's disease, as we gave example before, and other neurodegenerative diseases, as an example, is Huntington disease. Huntington disease can be another example for autophagia. After this autophagia, we discuss intracellular accumulations. You see, through these four ways, we can have intracellular accumulations. Here, for example, due to abnormal metabolism, there is fatty liver. Lipid is accumulated inside cell. Here is the second one, defect in protein folding or transport accumulation of abnormal proteins. Here, due to lack of an enzyme to make soluble products from complex substrates, there will be again accumulation of some things, for example, these are called storage diseases, such as lysosomal storage diseases or glycogen storage diseases. It depends on the enzyme that is deficient, and again, as a cause of intracellular accumulations. And there are different names here, such as Tay-Sachs disease. Tay-Sachs disease, deficiency of sphingomyelinase. The different names, different enzymes. It's not easy to memorize all the enzymes with diseases. And if the indigestible material is exogenous and is indigestible by the cell, they are again accumulate. So accumulation of exogenous materials. So here in intracellular accumulations, maybe there is accumulation of a normal substance. It's normal, but due to lack of packaging, lack of proper folding and transport, this accumulates inside the cell. Maybe it's an abnormal substance due to a mutation, a genetic derangement, and then this is accumulated inside cell. And maybe there is lack of enzyme in a metabolic pathway and cause diseases called storage diseases, including lysosomal storage diseases, glycogen storage diseases. And maybe it's exogenous material which is indigestible. Exogenous indigestible. Abnormal protein, as we said in degenerative, neurodegenerative diseases, that there is misfolded protein. Or another example is alpha-1 antitrypsin deficiency, which causes accumulations inside liver cells. And normal, due to lack of proper packaging and transport. An example for this is, for example, if a patient has a proteinuria. Normally, very little protein is excreted through the glomerulus. But in chronic kidney diseases, such as different types of glomerulonephritis causing syndromes such as nephrotic syndrome, nephritic syndrome, there is severe proteinuria. And this protein, through its way to be excreted, is reabsorbed by the tubular cells, tubular epithelial cells. And the tubular epithelial cells accumulate the protein, which is normal, has normal structure, but is excreted. So its structure is normal, but the patient has proteinuria, it is reabsorbed in tubular epithelial cells. So these are the causes of intracellular accumulations. Now we start with the lipids. Lipids can be accumulated in cells in the form of triglycerides, causing steatosis or fatty change. Fatty change or fatty liver disease is a common disease. In Western world, the most common type is alcoholic liver disease. In Asian countries, its cause is most due to diabetes mellitus, obesity. So this is a steatosis where triglycerides are accumulated inside cells. Another type of lipid that can be accumulated is cholesterol and cholesterol esters. So cholesterol can be accumulated in atherosclerosis. So lipids can be triglycerides that can cause fatty change or steatosis. This is due to accumulation of triglycerides. But cholesterol can also be accumulated with and also cholesterol ester. This is the picture for the fatty change due to accumulation of triglycerides. These vacuoles are accumulation of lipid inside cells. Normally we don't have these vacuoles. This is a fatty liver. And in cholesterol, one example is atherosclerosis. In macrophages and the smooth muscle cells of the intimal layer of arteries, including aorta, cholesterol and cholesterol esters can accumulate, and these macrophages and also smooth muscle cells, cholesterol and cholesterol ester accumulate and make multiple vacuolation inside the cell and make foamy cells, foamy macrophages. Foamy, we call it foamy. Macrophages, also in the smooth muscle cells, these are accumulated and make the atheromatous plaque, which can be dangerous. Atheromatous plaque. Here, so cholesterol and cholesterol ester are accumulated inside cells, but sometimes these accumulated cholesterol causes rupture of the cell, and this cholesterol comes out and crystallize, make needle-like structures make a morphology in the tissue. We can see cholesterol clefts. Cleft. They are empty spaces that can be seen in tissues due to extracellular cholesterol. So this is atherosclerosis. Another example for cholesterol accumulation is xanthoma. Have you heard so far of xanthoma?
No.
When we use the suffix oma, we mean that there is a formation of mass. Oma is the suffix for benign, not malignant tumors. But also, any time that we have a nodular mass formation due to any cause, we use the word oma. Xanthoma is the accumulation of cholesterol and cholesterol esters in the connective tissue under the skin and also in tendons, in skin and tendons. So this cholesterol is accumulated and makes many nodules and masses. For example, in a familial hypercholesterolemia patient, the patient can have nodular masses here on the elbow or on the Achilles tendon. So these are composed of cholesterol. Also more commonly, you have seen some people that they have yellow-white small dots on skin. These are macrophage-laden macrophages in the subcutaneous area and also maybe in the tendons. So this is another example for cholesterol accumulation. Another is cholesterolosis. Cholesterolosis is the presence of macrophage-laden. When a cell is full of cholesterol, a macrophage is full of cholesterol, we say it is macrophage-laden. Macrophage-laden cells in gallbladder. Do you know gallbladder in Persian? Kise safra. Also you use the same, kise safra, that bile is formed there under the liver.
Kise saffron, like Arabic.
The same.
Yeah.
Gallbladder, in this, the mucosa of gallbladder, accumulations of cholesterol-laden macrophages are seen. These cells are, you see, they are foamy. If you look carefully, they are foamy cells, so very light colored macrophages. Here is the accumulation of cholesterol-laden foamy macrophages in the mucosa of the gallbladder. Is the epithelial layer, is the lamina propria. It is called cholesterolosis. Another example of a cholesterol accumulation is a storage disease called Niemann-Pick disease, type C disease. There is cholesterol accumulation in this disease. After cholesterol, proteins that I explained it also in the mechanisms of intracellular accumulations. In this picture shows tubules of kidney that have reabsorbed all this reddish material inside cells due to severe proteinuria. So this is a normal protein, but due to proteinuria, it has been reabsorbed by the tubular epithelial cells. Protein reabsorbed, but when the proteinuria is treated, it can disappear. So it is reversible. This is a reabsorption of normal protein, but this type of accumulation, as I said, can be abnormal type and is present in neurodegenerative diseases. Some of the cells, another type of cell that can accumulate protein is plasma cell. Plasma cell is formed by B lymphocytes. B lymphocytes that, for example, if you imagine this is a B lymphocyte, then it is changed to plasma cell, has a peripheral nucleus. Is plasma cell, its chromatin has a special feature of cartwheel type. This is a plasma cell. In a tumor called multiple myeloma, which is a malignant tumor of plasma cells are increased in number and they contain a lot of protein as inclusion, and these are called Russell bodies. So another type of protein accumulation is in plasma cells called Russell bodies. And another type of proteins are the cytoskeletal proteins. So cytoskeletal proteins are proteins that give the stability of the cell. For example, microtubules, actin, myosin, and intermediate. They are divided according to their size. Intermediate type. Microtubules that are the largest, around 20 to 25 nanometer. This myosin is larger, around 15. This is around 5. And intermediates are around 20. This intermediate type of filaments again have different types. So these are all proteins filamentous type. Intermediate type of proteins have again different types. Keratin Keratin intermediate filament is present in epithelial cells. Vimentin in connective tissue. Neurofilament in neurons. Desmin in muscle. And glial intermediate filaments in astrocytes. So, these proteins can be used in special types of staining in pathology for diagnosis. We are studying, for example, a type of poorly differentiated cancer, but we can't say, we can diagnose that it is a cancer, but we can't say, define its origin, that is of epithelial origin, neuronal origin, muscular, or what else. So here we use special stainings. For example, if the tumor cells are stained with keratin, we will understand that this type of poorly differentiated cancer is of epithelial origin. So this will help us for definite diagnosis. These are different types of proteins according to size. The term hyaline change, hyaline change is not a specific, doesn't show a specific type of accumulation. If under the microscope we see pinkish homogeneous material, we say that there is hyaline change. It can be protein, it can be carbohydrate or whatever. So it's a non-specific definition, hyaline change. For example, in fibrinoid necrosis, the hyaline change around the vessel is due to extravasation of protein, plasma protein. So in that case, it is protein. Glycogen can also be accumulated inside cells in glycogen storage diseases, and also in diabetes mellitus it can be accumulated in different types of cells. So storage diseases include lysosomal storage diseases, glycogen storage diseases, or glycogenosis. And the pigments. The last part in intracellular accumulation is the pigments. Pigments can be exogenous or endogenous. The most common type of exogenous pigment is, can you imagine? The most common type of pigment that can be accumulated in our cells from the environment. Can you imagine what is it? What? Carbon. Yes. In air polluted cities, we respirate, and together with oxygen we respirate many dangerous things such as this exogenous pigment carbon. So a normal lung should have a pink-gray color, but in most of the people who live in cities, the liver has brown-black color. So this is due to carbon, and its accumulation in lung is called anthracosis. Anthracosis means accumulation of carbon. And a disease state is seen in those who work at coal mines. Workers in coal mines can get coal workers pneumoconiosis. So in cold workers, pneumoconiosis is a pathologic state of carbon accumulation in lung tissue. What about and tattooing? Tattooing is also an example of an exogenous type of pigmentation. The dye that is used for the ink that is used to tattoo, it causes pigmentation that is irreversible, that is present forever.
No, in the blood it will stay.
It is accumulated in dermal macrophages. You cannot remove it. You should remove the skin itself, all the skin.
The epiderm cell.
So, and sometimes
Just from the outside you can remove.
tattooing is the formal type of tattooing is permanent. Permanent pigmentation. You can't remove it. So sometimes as a joke is said here that it can cause embarrassment for the person, or sometimes with embarrassing consequences for the bearer of the tattoo. Endogenous pigments. Endogenous pigment, one of them is lipofuscin. Here, this is the cardiac cells myocytes that you see this yellow-brown pigment in cells. This is lipofuscin granules. It is seen in cell aging and also in stressed, injured cells. So lipofuscin is seen normally in aged cells. Another name of lipofuscin is wear and tear pigment. Lipofuscin is composed of lipid and protein.
Don't do that.
Due to lipid peroxidation. So it shows injury due to free radicals. The injury due to free radicals causes lipid peroxidation of membranes, and this causes the production of this lipofuscin pigment. So by itself, lipofuscin is not injurious. It's a sign. It shows that there is a cell injury due to free radicals. So that can be seen in any injurious agents that cause free radical production. And as a physiologic example is cell aging. So lipofuscin is one of the endogenous pigments. This is an electron microscopy of this cell, its nucleus and perinuclear accumulation of lipofuscin in lysosomes.
And the cause of the disease will be oil. They
Oil.
have free radicals oils, like we have such kind of oils. They have many free radicals, and they make cancers or something.
Which oil?
For example, the
You mean the...
home we use it every day.
No. This lipofuscin is the action of free radical injury. The free radicals, as I told you, are superoxide or hydroxyl,
You mean all
nitric
the oil?
oxide. They are free radicals. During their action of free radicals, there is the reaction of lipid peroxidation, and through this, these pigments are formed. Another pigment is melanin. Melanin is a brown-black pigment in melanocytes. And practically it is only in the endogenous brown colored pigment. Another pigment is hemosiderin. Hemosiderin here in this picture, this is liver tissue. You see that it's nearly similar to lipofuscin. It's present in hepatocytes that are bigger cells. So how can we diagnose that this is iron in hemosiderin or lipofuscin? Here we use some special staining called Prussian or Prussian blue stain that binds hemosiderin. So this is a special kind of staining that shows this pigment is iron, not bilirubin, not lipofuscin. So special staining is important for diagnosis. Hemosiderin is the accumulation of ferritin. Ferritin is protein that it's the storage form of iron. And hemosiderin is an insoluble complex of ferritin. It can be seen in diseases such as hemochromatosis of liver. Also, those people who have massive blood transfusions, they can have blood overload. Whenever there is iron overload, hemosiderin can be seen inside cells. Also in local injuries, if any bruise, a trauma is seen anywhere locally, then we see different colors during time. Green, blue, red. This changing of colors is the reactions that are seen in when the blood is extravasated from vessel. Then one of the changes is the deposition of iron as hemosiderin. So locally, hemosiderin can be also seen in, for example, bruises. So this is the part of intracellular accumulations. And in the last, if you want, I can also explain calcification if you are tired.
Too many things.
Yes, because next time I will explain after the quiz. I think we will have time because we can explain the calcification, and if we had time, cellular aging.
This part don't include for exam,
no.
yes?
And the exam will be
Necrosis,
before
apoptosis.
autophagia. Before autophagia,